Patients with serious mental illness often stabilize in an inpatient unit, receive a list of appointments, and discharge into the community. Shortly after, the intensity of their care drops, and they return in psychiatric crisis. Between the restrictions of a hospital and full independence sits the Specialized Mental Health Rehabilitation Facility, or SMHRF. These residential settings act as a 24-hour training ground where individuals restore adaptive functioning and daily living skills. The legal and therapeutic engine of an SMHRF is the 15-hour programming rule. Facilities are mandated by the state to provide a minimum of 15 hours of structured treatment programming per week for each consumer. This programming relies on manualized evidence-based practices like illness management and recovery, or IMR, and the Wellness Recovery Action Plan, or WRAP. Delivering these complex curriculums is impossible for a single practitioner working alone. It requires a diverse cast of clinical and operational staff, licensed practitioners of the healing arts, qualified mental health professionals, rehabilitation services aides, certified recovery support specialists, and nursing staff. Despite operating under the same roof, these professionals frequently work in isolated silos. They execute their specific tasks without visibility into what the rest of the care team is doing at that exact moment. A SMHRF is a highly interdependent ecosystem. Forcing these roles into operational silos engineers systemic breakdowns. We are going to dissect a theoretical high-acuity admission. By mapping the exact sequence of events, we can observe how a single procedural failure at the front door cascades into a facility-wide crisis. Clinical skill cannot sustain a facility's therapeutic mission without the structural integrity of interdisciplinary communication. The pre-admission phase is the operational choke point for facility safety. It dictates whether an arrival is therapeutic or hazardous. In a synchronized workflow, admissions conducts an initial screening. The director of nursing uses this data to prepare medical documentation. The LPHA must provide explicit sign-off to stratify violence risks. Before admission, the interdisciplinary team conducts a risk huddle, the ultimate safety checkpoint. The team reviews the data and finalizes a concrete mitigation plan. This document dictates the consumer's specific rooming assignment and establishes tailored staffing observation levels. This synchronized, step-by-step workflow constructs the invisible architecture that actually maintains the facility's clinical safety net. Real-world operations introduce intense pressure. Admissions coordinators are frequently pushed to fill vacant beds as quickly as possible to maintain facility revenue. The fracture occurs when admissions accepts a high-acuity transfer but decides to skip the IDT risk huddle to save time. This bypasses the LPHA's required sign-off on violence risks, committing a severe policy violation. This single deviation blinds the rehabilitation services aide supervisor, who receives no evaluation of adaptive functioning and cannot assign appropriate direct care support. The failure cascades into the nursing department. Nurses arrive for their shift without pre-populated charts or specialized risk protocols to guide medication and behavioral management. The consumer is assigned to an unprepared room, creating immediate logistical friction and generating interpersonal conflict the moment they arrive. Administrative silence converts a routine admission procedure into a facility-wide risk. The exact moment the consumer arrives at the facility doors determines the trajectory of their recovery. An ideal orientation relies on a dual-track process driven by direct care staff to establish rapport and mitigate initial anxiety. RSAs manage the operational baseline. They catalog belongings, check vital signs, and formally orient the consumer to medication procedures and facility rules. CRSS run a parallel track. As peer specialists with lived experience, they provide a warm handoff, explain expectations, and model recovery principles. In a fractured admission, this dual-track support does not exist. The consumer arrives into an unprepared, chaotic milieu. The RSA is scrambling to prepare the physical living space at the last minute, while the CRSS is completely absent from the orientation process. Stripped of structured, empathetic communication, the new admission experiences a soaring level of psychological distress. Neglecting orientation protocols guarantees the consumer's first experience of the facility is trauma rather than treatment. The immediate clinical consequence of this chaotic arrival is a severe, unmitigated spike in the consumer's psychiatric symptoms. Without an established safety plan, this escalating environmental stress predictably culminates in a verbal or physical outburst from the consumer. The facility responds by deploying internal policies, specifically the Resident Incentive and Contingency Management Program, or RICEMP. The RICEMP contains a specific mandate that triggers an automatic, punitive response for symptom-driven aggression. A drop to Level 1 enforces severe operational restrictions, stripping the consumer of privileges and revoking their community passes. This creates a direct contradiction. The facility uses coercive measures against a consumer to address a crisis engineered by the staff's own procedural failures. Enforcing this punitive response destroys trust and actively sabotages the transdisciplinary team's ability to build a functional therapeutic alliance. Penalizing a consumer for a systemic administrative breakdown is the exact opposite of evidence-based psychosocial rehabilitation. To correct these failures, facilities must return to the foundational objective of the SMHRF, preparing individuals for safe community reintegration. Clinical severity does not prevent an individual from achieving functional recovery, but a fractured operational system will. The pre-admission process has absolute non-negotiables that staff must execute every single time. The pre-admission risk huddle and the LPHA sign-off are legal safety mandates. They are not optional administrative suggestions that can be bypassed for convenience. Delivering the 15-hour mandate requires the vital interlocking dependency of the LPHA, QMHP, RSA, CRSS, and nursing roles. True patient-centered care is only achieved when this synchronization is strictly maintained across all departments. A facility's operational workflows and interdisciplinary communication function as the actual treatment environment. When staff protect their interdisciplinary communication processes, they protect their consumers.